Hi, this is QD Clinic, brought to you by Room Now Live, a fabulous meeting coming up in a few weeks. Let me just tell you the faculty. Mike Hollers, John O'Shea, Mike Weinblatt, Len Calabrese, me, Lisa Samaritano, Eric Madison, Ted Pincus, Fred Wolf, Maddie Feldman, Artie Kavanaugh, Philip Conahan, Eric Ritterman, Elaine Husney, John Ravel, Georg Schett, Ron Van Vollenhofen, Philip Seo, Carol Langford, Paul Monarch, and I think I left a few out. It's a killer faculty. RoomNow.live to register. Today's case is secondary loss of efficacy and what to do about it. 25-year-old gal with rheumatoid arthritis, probably about 5-6 years, comes in. Has been doing well. Actually, I guess it's only 3 years because she's been on a TNF inhibitor for about 2.5 years. She's on one of those first-line TNF inhibitors you have to use. Was doing great. Had a few aches and pains at her last visit 6 months ago. Says that since the last 6 weeks, she's been worse with pain all over. I thought it was going to be sort of secondary pain or fibromyalgic pain, but lo and behold, on joint exam, she's got a ton of joints. I mean, I think her joint count was 11 tender, 10 swollen. It was a little bit surprising. And she says that she's been very compliant with the medicine, taking it as prescribed. And so the question is, what do you do? Do you treat this as a flare? Do you treat this as secondary loss of efficacy? I call this a secondary loss of efficacy, and I treat it by changing her drug. What am I going to change her to? She was previously on methotrexate and a TNF inhibitor and did well just on a TNF inhibitor. I could have added back methotrexate. I changed her TNF inhibitor to another TNF inhibitor. And why did I do that? Well, first let's go over some of the data on loss of efficacy. Primary loss of efficacy is a drug that never works. So people who've never been on a TNF inhibitor who are on methotrexate and then go on a TNF inhibitor, it's the 60-40-20 response. 60% are going to have an ACR20. That means 40% of patients will have a primary loss of or lack of efficacy. Those who respond and then lose response over time, those are called secondary loss of efficacy. So the numbers on primary loss are between 40 and 30%. The 2016 Accelerate study done by Roy Fleischman and others compared head-to-head adalimumab versus certolizumab and showed in an open label randomized study that 70% of people responded right out of the gate at their endpoint, meaning that 30% were primary non-responders. In that study, they did a crossover. So primary non-responders were then switched to a second or the alternative TNF inhibitor, and they showed that about 50% of those patients or 55% of those patients responded. That means overall a total secondary response of about 40% of patients. So you lose quite a bit in primary non-responders. The data on people who switch, usually secondary loss of efficacy, secondary non-responders, about 50% or more will respond to the second TNF inhibitor, but then it goes down. So you go from your first TNF inhibitor, 60-40-20, that's ACR 20, 50, and 70 responses respectively, to your second TNF inhibitor, where it's now going to be 50, 30, 15, and a third one would likewise go down to 40, 20, 10. But those are all in people who, again, don't respond to the first and then go on to the second. So again, if you're a primary non-responder, you probably shouldn't be changing to another TNF inhibitor. Your levels of response are going to be lower. Instead of 40%, you can do 50 to 60% if you use another MOA or a small molecule inhibitor like one of the JAK inhibitors. I think the finer points of this are what to do when you're a secondary. This patient had her first TNF inhibitor. She's a secondary loss. The data on going to a second inhibitor, second TNF inhibitor, are good as far as the outcomes when you are switching for either toxicity reasons or for a secondary loss of efficacy. So this patient who goes on a second TNF inhibitor actually has a 60-40-20 chance of doing well with her second TNF inhibitor. But again, I want to remind you, if this was because she never responded to the first one, her chances wouldn't be 60-40-20. It might be 40 or 50% for an ACR20 response with the second drug. That's why I'm saying if you're a primary non-responder, go to another MOA. If you're a secondary non-responder, you can use a second. I don't know about using a third. That doesn't seem smart to me. That's the story with secondary loss of efficacy. Let me know what you do when you see me.